esteemed team from Stanford University. So we have Dr. Peter Acker. So Dr. Acker is an emergency medicine physician. He is an associate professor of emergency medicine at Stanford University. And his other interests are global health and improving healthcare systems across the world. You will hear him speak not today, but on Monday we have another session. We'll send you the links to the session on Monday. You can view the session online. So we have Dr. Patrick Lanza, who is also from Stanford University. Dr. Patrick is also going to speak on Monday, so you'll not hear him today. Dr. Patrick is also an emergency physician. He is also specialized. He's doing his fellowship in ultrasound in emergency medicine as well as global health. And the main speaker today is Dr. Enoch Obey, who obviously is with me here at Stanford University, and he is now going to speak about laryngeal mask airways. How many of you have seen laryngeal mask airways? Good, well done. And I know all of you are very new, so you will be definitely seeing laryngeal mask airways. So this is an important an important piece of equipment.
You can talk with
Speaking about what is the evidence behind the usage of LMA and when we can use LMA and what is the importance of it.
Now people can share, sir. We already
Yeah.
Is there a way to share?
And
like,
also please welcome Dr. Raman Rao, who is the director of कितने लोगों को इंग्लिश मुश्किल लगता है यहाँ पे? दुश्मन है क्या इंग्लिश हमारा?
the PowerPoint notes. The notes in the
तो मैं ये बोल रहा था, तीनों का तो इंट्रोडक्शन हो गया, तो नाम समझ गया, ठीक है? तो डॉक्टर इनॉक जो है अभी LMA के बारे में बात करने वाले हैं। LMA का मतलब है Laryngeal Mask Airway।
देखिए हो the PowerPoint.
इसका क्लास हुआ है? नहीं, तो एयरवे क्लास में आएगा। तो ये कब यूज कर सकते हैं हम, कौन से पेशेंट में यूज कर सकते हैं, और ये यूज करने के लिए क्या क्या एविडेंस है, पुरावा क्या है इसके पीछे यूज करने का, ये सब आपको अभी एक्सप्लेन करने वाले हैं डॉक्टर इनो। ठीक है, अगर आपको कुछ बीच में डाउट आया तो लास्ट में 15 मिनट्स विल बी डेडिकेटेड फॉर आस्किंग क्वेश्चंस और एनी डाउट। So even if you don't understand something and if you want to ask in Hindi, you can ask me and I'll translate that for them and they'll explain it to us. Okay? Right. Before we start, any doubts? Good. So over to you, Dr. Ino.
Is it sharing now?
You want to share it?
Like, am I okay to start?
Yeah, just give us 1 second. Yes, Zoom open in video open. Sorry, screen share. Yeah, I think you're okay to start now. Okay. You can use that slide.
Or you're fine. I want to see my notes. Anyway.
Okay.
Perfect. And should I speak into the microphone?
Yes, yes. You can use the mic as well.
Yeah.
Have this louder.
Hello?
Just
Hello? Hello? Good afternoon. So as introduced, I'm Dr. Enoch Obing. I see some familiar faces. I was here a couple months ago, and thank you for returning for another lecture. Hopefully it was good enough for you to come back and not just mandated, but we'll see. So I'm going to talk about laryngeal mask airways. And I know a lot of people here are either EMTs or paramedics. Is anyone here not an EMT or not a paramedic? Okay. Is everyone here familiar with LMAs or something similar? Okay. Who here, because I know some people here are still in training, who here has never used an LMA?
Them must have not. Majority of the people sitting around this side.
Okay. You will see later that there will be some interaction. So we'll get there. But I'm gonna give some background information. We'll briefly talk about how to use it, but then the bulk of this presentation will be on the literature review. And then after that, we'll give a bit of a conclusion. And that conclusion is gonna be, should we, as emergency medical service providers, be using LMAs, particularly more frequently, or are they something we should, lay at the roadside and never touch again? So what is a supraglottic airway? Specifically, LMA, Laryngeal Mask Airway, is a brand. From now on, because most of the literature uses the term supraglottic airway or extraglottic device, you will hear me say SGA. And so since here the brand we use is the Laryngeal Mask Airway, when I say SGA, just assume it's LMA. But the data, the literature, all usually just keep it vague. They purposely try not to use the brand names. So what is a supraglottic airway? There's certainly different types. Combi tubes, laryngeal tubes, eye gels, air cues, LMAs. When I say SGA, it can mean any of those devices. But what do those devices have in common? For the most part, it's all about anatomy, all about where they insert. Can anyone here tell me where LMAs usually stop? So the SGAs or LMAs, they usually stop at that upper portion of the airway. And the anatomical cutoff is the larynx. And so there would be a picture of the larynx. For those who have intubated before, this should be a picture you're more familiar with. This is the way you would see it at the head of the bed. But why does this picture matter if we're talking about LMAs? Does this picture matter? Does the anatomy matter if we're talking about LMAs? It matters, but you will not see this when inserting an LMA. For those of you all who have not inserted an LMA before, one of the big benefits is that LMAs are what's called a blind airway device. LMAs, you don't have to see where they're going. LMAs, you can insert it and assume if you're inserting it correctly, it will land in the correct position. So it's what's called a blind airway device. You don't have to see the vocal cords to insert it. If you insert it correctly, you assume it will land in the correct position. And so obviously one of the big advantages, it's also supposed to be easier to use when compared to endotracheal intubation. And endotracheal intubation, a lot of people consider the definitive airway or the gold standard when it comes to airway management. Who here has intubated before? Okay. So a very early crowd still in the training. By the end of your training, you will hopefully be a master intubation. But in situations where you would likely consider a intubation, maybe we should be considering using LMAs instead. So how to insert an LMA? It's super easy. And I'll go back to a picture so you can kind of get a view of it. Realizing that it has that mask portion, and that's why they call it in Laryngeal Mask Airway. There is a cuff that you'll insert. So notice the cuff, like any tube, you check the cuff for leaks, and then you deflate the cuff, apply lubricant, lift the chin, insert, inflate cuff, attach the bag valve mask, and you're essentially done. 8 easy steps. It's supposed to be designed to be very easy. And when inserting an LMA, the reason you don't need to visualize is because when you insert an LMA, it goes essentially the path of a food bolus, where when you're inserting the LMA, it rides along the hard palate, it covers the esophagus, and then the posterior portion sits over the larynx, and when inflated, it creates a seal over the larynx. So ideally, you push it in far enough where the esophagus is covered by the cuff of the device, and then when inflated, it sits over the larynx. Don't need to visualize the larynx for this to happen. Can someone tell me any indications for using an LMA? Upper airway. One more time. Okay. Compromised upper airway. Correct. Any other times you would consider using an LMA? I hear a lot of whispers. Can someone speak up? What is the most people's go-to indication for using an LMA? Most training shows LMA as a backup airway or a rescue airway. And there's a lot of difficult airway algorithms, patients that are difficult to intubate. You can consider bougies, you can consider LMAs, you can go back to bagging the patient, but most people are taught or trained that an LMA is a backup device. There are newer supraglottic airways for which you can intubate through them. You can do certain procedures through them. Some anesthesiologists will use them primarily for shorter surgeries. So it's leaning away from just a backup device, but we want to review the literature and make sure we're using it in accordance to evidence-based medicine. What are contraindications to inserting a LMA or a supraglottic device? Okay, I heard secretions. I think I heard trauma. What else did I hear? I hear a lot of discussion amongst yourselves, but I can tell there's some good answers out there. I just need someone to say it. So there's tend to be relative contraindications. Patients with an intact gag reflex tend to not do well when you insert something designed to sit at the level of your esophagus and cover the larynx. If there's concern for abnormalities of the oral pharynx or proximal esophagus, esophageal varices in a cirrhotic patient would be a situation where you would probably not want to use an LMA. Caustic ingestions may make it difficult to insert an LMA or cause issues later. And the other big obvious contraindication is a airway obstruction by a foreign body. And the concern is that an LMA can just push obstructions further or may not reach certain obstructions. So there is a bit of a supraglottic airway difficult situation mnemonic. I've since realized there's a mnemonic for anything airway related. I'm sure you all have heard different mnemonics, but the go-to mnemonic for supraglottic airway is ROGS. Hit the picture of the ROGS. R, restricted mouth opening. Obviously, having restricted mouth opening or small mouth will limit ease of use. O, obstruction. Theoretically can potentially push obstruction further. And any sort of obstruction below the level of the glottis will not be relieved by an LMA or supraglottic airway insertion. Distorted airway anatomy, that seems obvious. Stiff lungs or C-spine. Lungs with poor compliance, like those in asthmatic patients, can make it difficult to ventilate through an LMA or a supraglottic airway device. And C-spine immobility can sometimes lead to a poor seal in some people. But we still can use it in trauma and still frequently do. Just realize the seal may not be as good. And like any sort of difficult airway mnemonic or difficult airway situation, just use your common sense, think it through, but this is a backup in case you need that little extra memory reminder. So now we're going to go through the literature. People use LMAs, people use supraglottic airway devices, but should we be using it? Is it evidence-based medicine? What does the most up-to-date literature say? So for this next portion of the talk, it will be interactive. There are going to be true and false questions. Everyone has to vote. Everyone has to vote. We won't move on. True or false. Okay? Everyone agrees. Everyone will raise their hand. True or false, 14% of LMAs or supraglottic airways are misplaced by EMS. And realize that this will be 14% is there, approximately 14%. Obviously, if it's 15, 16, I'm not going to try to trick you. This is approximate. Who thinks the statement is true?
Next question.
Who thinks this statement is false? Everyone has to raise their hand and vote. We're gonna try it again. Who thinks this statement is true? Who thinks this statement is false? I'm looking at someone with a, is that a green shirt who didn't raise their hand? What is in the fourth row, third row? He's saying through or false? What has to vote, through or false? What is that?
So is answer है either true or false.
Everyone has to vote, okay? So there was a cohort study about this. Extraglottic airway device misplacement, a novel classification system, and findings in postmortem CT scan. They had a group of patients who died with a supraglottic airway device in place. Per protocol, they left the device in place. The patients were then sent to the coroner's office for autopsy, but before that, they CAT scanned those patients. When they CAT scanned those patients, post-mortem with the supraglottic airway device in place, they found 14.4% of those patients had the supraglottic airway device misplaced. But I know what you're wondering, oh, but it's so easy, just put it in there, just insert it. A majority of the misplacement was secondary to poor depth. When inserting in these airways, you have to insert it all the way until you meet resistance. That way, you know the esophagus is covered by the cuff. That way you have a good seal. As any study, there is flaws. This study in particular, they say they could have overestimated that 14%. There is a possibility some of these patients, the supraglottic airway was moved or dislodged on the way to the coroner's office or the way to the morgue. But there's no way we could know that. And even with those potentially displaced supraglottic airways, they were still likely providing oxygenation and some ventilation. Not the perfect amount, but even when inserted poorly, they still suspect that it was working to some degree. True or false? Misplaced supraglottic airways result in major injury 7% of the time. Who thinks this statement is true? Who thinks this statement is false? In the third row, blue shirt. False? Okay. So false. 7% would be a 7% would be a lot. 7% would be 7% would mean we got to rethink this whole situation. Thankfully, only about 1.5% they noted injuries in those post-mortem CAT scans. And in those post-mortem CAT scans, like I said, only a small percentage. They did note some pharyngeal or esophageal perforations in 2 hyoid bone fractures. And since these are post-mortem and they're having autopsy performed, even despite these injuries were not the cause of death. The cause of death in these patients were pulmonary embolism or coronary artery disease. True or false? And this is by EMS. We're talking by paramedics, by EMTs. 12% of endotracheal tubes, and endotracheal tubes implies endotracheal intubation, not a supraglottic airway. 12% of endotracheal tubes are misplaced by EMS during intubation. Who thinks this statement is true? Who thinks this statement is false? Someone in the back with I saw his hands coming up now. For the people who think it's false, do they think it's higher or lower than 12%?
Probably higher than.
Higher than 12%. You are not a confident. So there's a study for that. So this was a prospective observational study in a urban, rural, and suburban environment. This is one of the bigger studies done in the late 90s, early 2000s that's still quoted today. And they had EMS intubate for situations where EMS intubated in the field. They brought the patients to the hospital, of course, and then the ED physician determined if the tube was in place, and then documented if the tube was in place. Documentation or determination of the tube being in place can be done through capnography, can be done through direct visualization, can be done by X-ray. Obviously, in the emergency department, there's more tools to determine if it's in place. So 12% misplaced by EMS. That is true. About 1 in 10 are misplaced. A majority of those in the esophagus. So there's obviously levels to misplacing. Being a little high, not a big deal. Right main stem, probably not a big deal. Getting into esophagus, not gonna oxygenate, not gonna ventilate in the esophagus. So this is a reminder that, people make mistakes. You're not alone in making mistakes, but this is a average. There's of course going to be some EMTs, some paramedics where they misplaced a tube 1%. There's going to be some who are misplacing the tubes 20%. This is an average. Try to be that 1%. There is a bit of nuance to this as well. If you notice, the misplaced ET tube was 12%. The misplaced LMA was about 14%, probably a little overestimated. So they're about the same in terms of the misplacement, but realize there's levels to this. A misplaced LMA can still, like I said, misplaced LMAs tend just to be high, not considered low enough. A misplaced LMA can still provide oxygen, probably ventilate to some degree. A misplaced ET tube in the esophagus is not doing the patient any good. But before we make our decision that like LMAs are so great, let's kind of look at a little bit more research. True or false? Supraglottic airways compress the carotid arteries, thereby impairing blood flow to the brain. This could be pretty major. So, by show of hands, who thinks this is true? By show of hands, who thinks this is false? Okay. There's another study, impairment of carotid blood flow by supraglottic airway in a swine model, in a pig model of cardiac arrest. So here's what they did in this study. They took 9 pigs, they induced ventricular fibrillation, and they started CPR in these pigs. And then in these pigs, they inserted various supraglottic airways, including LMAs. And then they had a postmortem carotid arteriography. And in these pig models, it did show decreased cerebral perfusion in the pig model. Well, like any good study, one second. In any good animal study, you try your best to replicate it in humans. Does anyone change the answer knowing that in pig studies showed a decreased cerebral perfusion? So we'll say again, true or false, and I want to see if anyone changes the answer. Who thinks the answer is true? I'm surprised people aren't changing their answers after knowing what happened in another mammal model.
I think we need to know more about pigs and the anatomy of pigs and how is it comparable to human studies.
That's a good point, good point. But another study, this one a couple years later, radiographic evaluation of carotid compression in patients, human patients with extraglottic airway devices. So what happened in this study is they had 17 patients with a LMA or comparable supraglottic airway device, and these patients had CT angiograms. And they had a radiologist read these CT angiograms and say, is there signs of carotid artery or signs of a lack of signs of compression of the carotid arteries? Thankfully, in humans, there was no evidence of a carotid artery compression with an LMA. It was 3 years between this study and then the pig study. So there was about 3 years where people were very concerned that they were doing harm to patients by inserting LMAs. Thankfully, the research has shown that in humans, it's perfectly safe. And it is one of those things where there's likely differences in anatomy. Pigs obviously have different necks. They hold their heads at a different angle than humans. And if we're being honest, these devices are designed for humans, not designed for pigs. So probably not surprising. there has been a bit of a question of this study here is in essentially stable patients who can go to get a CAT scan or go get a angiography. There's some question of maybe an unstable patient or a patient in cardiac arrest would have different results. True or false? Supraglottic airway use during cardiac arrest is associated with worse clinical outcomes when compared to a more definitive airway like endotracheal intubation. And by worse clinical outcomes, I'm talking about increased mortality, worse neurological outcomes at time of discharge. Are we ready to vote? Who thinks the statement is true? Who thinks the statement is false? Not everyone is voting. Let's in the third row, purple shirt. True or false? False. Okay. Let's do this one more time. Who thinks this statement is true? Who thinks this statement is false? There's a bit of divide separating the room. I don't know if it's the teaching. I don't know if you're copying your neighbor. So there was another study, because there's always another study, comparing supraglottic airway device versus endotracheal intubation for out-of-hospital cardiac arrest, which is what you all see when working in the field. Compared with endotracheal tube insertion, the endotracheal tube group, in terms of if these patients were able to survive, make it out of the hospital with decent cardiac function, there was concern that an LMA group potentially statistically significant with statistical significance did a little worse, but he couldn't prove it clinically. But this is one of those we have to actually read the paper. In this paper, they said the LMA group did worse, like a little bit worse, but they were using LMAs as a rescue device. So in this paper, people were intubated usually first, and then if they failed traditional endotracheal intubation, they would insert the LMA. So it's not surprising that if you failed the intubation and then inserted an LMA, that these patients are doing worse. So this is one of those where you can't just read the headline, you have to read the paper, you have to understand what you're talking about. Thankfully, a better study was done, a randomized controlled trial, not just an observational study, but a real randomized controlled trial. This was done out of the UK by the NHS, and they put people in two groups. They had half of their EMTs, paramedics assigned to an endotracheal intubation group. They had the other half assigned to a LMA supraglottic airway group. And when it come across cardiac arrest, half of the group was told use endotracheal intubation. The other half was told use an LMA. Obviously, if you're in a situation where you think the safer thing would be to use one versus the other, they said go ahead and do that, but try to stick within what you're assigned to. And this Airways 2 trial is a pretty big trial. They have a nice graphic, so you know it's a good trial. And back to our question. False. So question, SGA use during cardiac arrest is associated with worse clinical outcomes compared to endotracheal intubation. They had comparable outcomes in terms of morbidity, mortality, neurologic outcome when using either endotracheal intubation or a LMA or supraglottic airway device. But that's arguably not the most interesting part of this study. Among adult patients with out-of-hospital cardiac arrest, any type of advanced airway management was independently associated with decreased odds of neurologically favorable survival compared with conventional bag valve mask ventilation. Does anyone think why having a definitive airway could lead to worse outcomes for these patients? It almost seems like the opposite of what you'd expect. Any ideas why? It's one of those where the problem isn't the endotracheal tube. The problem isn't the LMA. The problem is that he weren't focused on compressions when inserting some of these devices. If you all have taken BLS, ALS, you've probably seen similar graphics where time away from chest compressions is associated with worse outcomes. And so when choosing any device, choose the device that allows you to optimize compressions. And I know a lot of you all will be in situations where there will be one driver and then one person working medically. So optimize compressions. In these situations in the UK trial, it's suspected that there was often a bit more of a team involved. So if you have to take the airway, an LMA is a good adjunct, but realize you don't want to spend too much time fiddling with it because that will take away from chest compression time. So if you're going to insert an LMA, make sure you're very confident about how you're inserting it. Make sure you can do it quickly. Be familiar with your equipment. And those are essentially a bit of my take-home points. Supraglottic airways, LMAs, are not just a backup for failed intubations. There's been good studies showing you can use it first line, particularly in out-of-hospital settings. They are safe. But more importantly, do what you're comfortable with. Do what will allow you to continue managing the patient best. And if that means a cardiac arrest situation, do what allows you to keep doing the chest compressions. And so if you take anything from this, I think you all should be more comfortable with using LMAs, get more comfortable with using supraglottic airways. That way you can provide the best care for your patients. So that will be the end of my presentation. Any questions? No
Any
questions?
questions? If you don't have, could push that. I have one question. So on the last study, there was a very interesting study where you mentioned there was worse outcome when they did the airway intervention. Was there any data in the study to suggest how long did they take to do the intervention?
Not in this study. I've seen other studies where I've commented on that, and I don't remember off the top of my head.
Okay,
But it is one of those situations where the recommendation is do not pause compressions to
Yeah.
insert the airway. Try to get the airway through the compressions. The compressions are the thing to focus on.
the reason I asked that because we sometimes teach that if you're doing some intervention, do it within less than 10 seconds. But if there's some evidence that even if that is the case, even if it's less than 10 seconds, if the outcome is going to be worse, then probably we should teach that away.
My,
I want to ask two questions.
Yes, just, yeah,
Yes.
sorry, yes.
I do think trying for that time for pulse check, trying to get it to as during that 10 seconds is ideal. Every now and then I'll have residents who ask like, hey, can we stop the compressions? I can't get the tube in. My answer is no, we're not going to stop compressions for you. Get better. Or we'll use an LMA. There was a question.
Raja wants to be unmuted.
Yes, sure.
Wants to ask that it's possible. that-
Let me try.
Speak.
You had a question while we're waiting?
Yeah.
Can you use the LMA for kids?
LMAs can be used for kids. You have to size it appropriately. The data isn't as robust in children. In almost all of these studies, the exclusion criteria was either 18 or younger. Once it was like 15 or younger. So there's not great data on it, but our LMAs sized for kids. And practice seems to dictate that you can use LMAs for kids just fine.
Doctor, can I ask a couple of questions?
Yes.
Really, it was a very nice presentation, especially the studies which you have projected about the carotid arteries and arteries is really interesting. I just wanted to know, are there any studies about the nerve compression with these LMAs, like any changes in the hoarseness of voice or something like that?
So and for the audience, the question was, are there any studies related to other changes when using LMA, such as hoarseness of voice or anything comparable?
Yeah.
I did not specifically look for that type of information, so I'm honestly not sure.
Because what I have seen in my practical experience is in some of the LMAs, the first generation LMAs, there is no such effect on changes in the hoarseness of voice, but especially the second generation LMAs, the what you call iGel. For some of the patients I have used, 75% of the patients, they came with a complaint of what you call a change or hoarseness of the voice. Maybe my technique was not appropriate, but they came with that complaint. So I'm just wondering, any studies are there for this LMAs where they can cause any changes in the voice, like hoarseness of voice or something like that?
I'm honestly not sure. I know the older generation supraglottic air devices sat over top the larynx, did not penetrate the larynx. So that's probably why those patients did not notice any changes. But there have been some devices, which you call like extraglottic, because it's over the airway and there is some part of it that goes into the larynx or very close to it. And I do wonder if those devices would be situations where patients would notice a bit of hoarseness of voice. But I'm honestly not too sure. Any other questions?
What is the percentage of use of LMS in US compared to the other supraglottic airway like combi tube and all? Do you use more of LMS or more of combi tubes?
So the two hospitals where I worked at, we use LMAs. Stanford uses LMAs, is that correct? And I'm honestly not sure why different hospitals choose which. I know sometimes it's about like cost, sometimes it's about contracts. But the two hospitals I've used at, use LMAs. And I'm being told Stanford uses iGels as well. But LMAs seems to be more popular to the point where a lot of people, when they talk about supraglottic device, they say LMA, just kind of because that's what they're used to.
If I say a word that now the LMS are so advanced, like third generation LMS and all, that you even in what you call in ventilating patients, in some of the patients, they are using this what you call as supraglottic airways, the third generation LMS, even in anesthesia maintenance also for long run, they are using this LMS. What is your comment on that? Is it advisable to do that, especially after COVID? Many of them, they started using LMS very regularly, and they are not using endotracheal tubes. Instead of endotracheal tube, they are using LMS even in controlled ventilation also, and prolonged surgeries for 4 to 5 hours. One of the cases what I have done is even was for about 4.5 hours, and there was a good touch that we didn't have any complication. We have done about more than 1,000 patients for ventilating for more than 1 or 2 hours, and we never had any problem. So what is your comment on that?
Okay, I'm just going to repeat it for the audience. The question is about using LMAs in lieu of or instead of endotracheal tubes for certain anesthesia related procedures.
Yeah.
I'm willing to admit my research for this presentation did not focus there, but I did come across some interesting studies where there seems to be a lot of people now using LMAs for short-term and longer procedures like we talked about. When using LMAs, there was one surgical center where the use of LMA versus endotracheal tube, they had a higher incidence of post-anesthesia re-intubation when using ET tubes, which was surprising to people. But then that same study also noted that it was likely secondary to like neuromuscular blocking agents and not the actual like method of intubation. So it's becoming more popular, but I'm willing to admit in terms of the operating room, I'm not sure what the most up-to-date recommendations are.
Thank you, Doctor.
Thank you. Any other questions?
So one question, like as we work for the pre-hospital care program. So what will be the duration after placing the LMA? How much duration we can place an LMA? Like the duration with the patient.
Like how long can an LMA stay in place?
Yes.
So LMAs can stay in place for hours. And there's been situations where LMAs will stay in place for days. At the hospitals I've worked at, they're almost always switched to endotracheal tubes, just out of practice. But in terms of anything related to EMS, you can insert the LMA and not have to worry about switching it over for an endotracheal tube, because there has been situations where patients in the hospital will have LMAs potentially for extended periods of time. So from an EMS standpoint, I think you could have the LMA inserted and not have to worry about switching it out like in the field or anything like that. Any other questions?
Some of the newer generation LMS, Doctor, what I was mentioning, which we are using, they have a port where you can put a tube into the stomach and then aspirate. So those LMS, I think you can use for a prolonged time. There are third generation LMS which have come into the market, and many of them are using that. Apart from that, the interesting thing is it has a through the same port. If you are not comfortable with the patient, about your ventilation to the patient, you can also intubate the patient through that. So I feel that with this newer generation LMS, you can maintain the patient for a very long time, even on ventilators also.
I have heard about some of the newer ones where they will allow you to intubate through it. So some people use these newer generations LMAs as their first line, knowing they can easily convert by intubating through it. So I have seen that as well. And I think I saw someone's hand up here. Yes?
So in the field, we failed into intubation, and we noticed there is soft tissue injury and there is bleeding. So can we still insert LMA after that?
If you notice bleeding after intubation? Is that the question?
Yes, after in the field, I tried intubation, when there is soft tissue injury. Like I hit the cartilage, the adenoid cartilage. So, and I noticed bleeding, still I can go with LMA.
You can still go with LMA. Obviously, any situation where you are repeating an intubation can have worse outcomes because of like swelling in the area, because of trauma in the area, but you can still try to insert the LMA. Just realize that you may have to use more lubrication because there may be some swelling in the area. And for patients where you are intubating, they clearly need a definitive airway. I would still proceed with an LMA, even if you do notice some bleeding after endotracheal intubation failure.
Doctor, my comment on that question, what he has asked, actually, he says that it has been intubated and there was a soft tissue trauma. So once the soft tissue trauma is there, as you correctly said, there will be bleeding. And my advice is don't shift on to LMA, because the main side effect or the problem with LMA is aspiration. So if you switch on to LMA, the blood which is clotted there or the blood which is oozing from that area will definitely drain into the trachea and into the lungs. So it's very dangerous at that time changing from endotracheal tube to LMA. Rather go for a try for putting an endotracheal tube itself.
Okay. And the comment was that after trying to intubate and not being able to intubate, there could be bleeding that can be aspirated into the trachea if you don't have a definitive airway. And so if you can get an endotracheal tube, I agree that's great. But I do realize that some paramedics, some EMTs just simply will not be able to get it. And so I'd rather have something in place than just continuing to unsuccessfully try that intubation. But ideally you would in that first try get it, hopefully that second try get it. But you know, some airway device that is sitting over the trachea and not in the esophagus is better than nothing. Any other comments or questions?
So for people listening online, we thank Dr. Enoch for this wonderful session. And thank you everyone for listening as well. So we'll be closing the online session. Thank you.